Okay, so picture this. You've got a patient, right? And they've got a chronic subdural hematoma.
Mm-hmm.
Now, we usually think surgery, but what if there was like a less invasive option?
Oh, interesting.
That's where this middle meningeal artery embolization comes in, MMAE, you know.
Oh, right.
And it basically targets the bleeding, like right at the source.
I believe you.
So naturally, I'm thinking, how does this MMAE actually stack up against surgery?
Yeah.
And what are the risks, the benefits, all that stuff?
Important question.
Absolutely. And that's what we're diving into today. We've got 2 studies.
Okay.
One's a meta-analysis looking at complications of this MMAE procedure. It's called Complications of Middle Meningeal Artery Embolization, a systematic review and meta-analysis.
Okay.
And the second one, that's a randomized controlled trial. It compares MMAE to just usual care. It's called Embolization of the Middle Meningeal Artery for Nonacute Subdural Hematoma. A lot of words.
Yeah, that's the mouth.
But really interesting stuff, right?
For sure. So you're basically saying we're moving away from just removing the problem with surgery
Yeah.
and more towards like controlling it
Yeah.
at the source.
Exactly.
It's kind of like instead of mopping up a spill, you fix the leaky faucet.
Perfect analogy.
Right.
Okay, but before we get into the weeds of these studies,
Yeah.
gotta set the stage. Chronic subdural hematomas, they're not exactly rare, are they?
No, especially in older patients.
Right, a little bump, a
Yeah.
fall, maybe they don't even notice it, and then boom, slow bleed, pressure on the brain.
Exactly. And then surgery's been the main treatment, but
Right.
recurrence rates are a real problem.
Oh, absolutely. They can be stubborn, these hematomas,
They are.
which is why this MMAE is gaining traction. It's less invasive, you know?
Yeah.
So let's jump into that meta-analysis on complications. Complications of middle meningeal artery embolization, a systematic review and meta-analysis.
Tell me about it. Well, it really digs into the safety of MMAE. They looked at 34 studies, 921 patients in total who had the procedure. This was published in World Neurosurgery.
Okay, and what did they find? High complication rate.
Actually, no, surprisingly low. And remember, we're often talking about older patients, maybe with other health issues.
That is good news. What kinds of complications did they see and how often?
They broke it down into 4 groups. So neurological complications like seizures or stroke, they happen in about 3.8% of the patients.
Okay.
Cardiovascular complications, things like a vessel rupturing or fistula forming, that was around 3.6%.
Got it.
Infectious complications like pneumonia, that was in 2.9% of the cases.
All right.
And then they had a miscellaneous category for everything else, and that accounted for 3.1%.
So overall, those numbers seem pretty manageable. What about deaths? Were there any reported in the study?
There were 2 deaths reported.
Oh, okay.
But, and this is important, neither one was directly because of the MMAE procedure. One was because of COVID-19, and the other patient was discharged on hospice care and had some pulmonary issues.
So emphasizing the fact that the procedure itself seems safe.
Exactly.
All right, let's move on to that second study then. The randomized controlled trial from the New England Journal of Medicine. This is the embolization of the middle meningeal artery for non-acute subdural hematoma, the MAGIC-MT trial. So fill me in on this one.
So they took 722 patients in China with symptomatic non-acute subdural hematomas. But here's the thing, 78% of those patients in both groups, they ended up getting burr hole drainage anyway.
So we're not talking about replacing surgery entirely, more like adding MMAE on top of usual care.
Yeah, and that's the question they wanted to answer. Does adding it on actually lead to better results?
Makes sense. What were the results then? Did the MMAE make a big difference?
Well, their main outcome was whether the hematoma came back or got worse within 90 days. And surprisingly, no statistically significant difference between the group that got MMAE plus usual care and the group that just got usual care.
So sounds like a bit of a setback, right? If it doesn't affect recurrence, what's the point?
Hold on, it gets interesting. MMAE might not have prevented the hematoma from coming back, but the group that got MMAE had significantly fewer serious adverse events, like 6.7% compared to 11.6% in the usual care group.
Ooh. So even if it didn't stop the hematoma from recurring, it maybe made the whole experience safer for the patient.
You got it. That's a big deal.
It is. Did they look at other things, like how well patients were doing after the procedure?
Yeah, they looked at a bunch of factors. Things like modified Rankin scale scores, which measure disability after a stroke or other neurological event.
Right.
They also looked at quality of life using a standard questionnaire. And interestingly, no big differences between the 2 groups after 90 days.
So taking all this together, what are the big takeaways for clinicians?
All right, 3 key points. First, That meta-analysis, remember. It suggests that MMAE is a pretty safe procedure. Low complication rate overall. Especially important because we're often dealing with older folks who might have other health problems going on.
Definitely reassuring. What's the second point?
Second, that MAGIC MT trial. It didn't clearly show that MMAE prevents recurrence.
Right.
But that lower rate of serious adverse events, that's big.
Yeah.
So MMAE has potential, but we need more research to figure out who benefits most and when's the best time to do it.
Not a slam dunk, but definitely worth looking into further.
Exactly. And the third point, maybe the most important one, shared decision making. We need to be upfront with our patients, explain surgery, explain endovascular options like MMAE, and help them make the best choice for them, taking into account their own risks and preferences.
Absolutely. Shared decision-making is key.
Absolutely. So, when we talk about shared decision-making, it's not a one-size-fits-all kind of thing, managing these chronic subdural hematomas.
Totally. It's all about tailoring the treatment to the patient, right?
Exactly. Like imagine you have an 80-year-old patient and they're on blood thinners, have a history of heart problems. Surgery in that case, way riskier, right?
For sure. Compared to, say, a younger, healthier patient.
Yeah.
Maybe a smaller hematoma, not as many symptoms.
Right.
Might just watch and wait.
Exactly. And that's where MMAE could be a good option.
Right.
For those who aren't great candidates for surgery. Less invasive, so potentially fewer of those serious complications.
Makes sense. You mentioned earlier about future research.
Yeah.
Focusing on, who are the best patients for MMAE and when to do it.
Yeah.
What questions specifically should these studies be asking?
Well, are there certain things that make some patients respond better to MMAE than others? Like, does the size of the hematoma matter? Or where it is? Or specific risk factors?
So not just aging comorbidities, but really looking at the hematoma itself.
Exactly. And then there's the timing thing. Remember the MAGIC MT trial? Most patients had burr hole drainage anyway, whether they got MMAE or not. So what if we did the embolization before surgery, or even as a standalone treatment in some cases?
Like, an ounce of prevention is worth a pound of cure. Maybe if you catch it early with MMAE, you could avoid surgery altogether.
That's the idea. We need more data, obviously, but it's definitely promising.
It is. And what about the long-term effects? The studies we've talked about have mostly looked at pretty short-term outcomes, like 90 days out.
Right.
So do the benefits, like that lower risk of complications, do they actually last?
That's the question. And are there any downsides that show up later? Things we haven't seen yet?
More research needed. Okay,
Yeah.
I'm curious. For you, what's the most exciting thing about using MAE for chronic subdural hematoma?
For me, it's the possibility of changing how we think about treatment entirely. Right now, it's surgery first, surgery only, pretty much.
Right.
But with MMAE, we might have a less invasive, maybe even safer option, especially for those higher risk patients.
It's like adding another tool to the toolbox.
Exactly.
More options for better care.
Yeah, and as we learn more about who it works best for and when to do it, I think MMAE is going to become more and more important for managing these hematomas.
I agree. So, bigger picture for a second.
Sure.
How does this whole MMAE thing fit into this trend of minimally invasive procedures we're seeing everywhere in medicine?
Oh, that's a good point. MMAE for chronic subdural hematoma, it's like a perfect example of this move towards less invasive stuff. Cardiology, orthopedics, oncology, everyone's doing it.
It's all about less trauma, faster recovery, better experience for the patient.
Absolutely. And usually it means fewer infections, fewer complications too.
Makes sense. But we can't do everything minimally invasive, right?
Oh, not everything.
But when we can, it's a win-win.
Yeah, for everyone.
Speaking of wins, that lower rate of serious adverse events from the MAGIC MT trial, that's pretty compelling, right?
Sure.
But like you said, it didn't beat usual care for preventing recurrence. Why do you think that is?
Well, remember, most people in both groups still had surgery, that burr hole drainage. So it wasn't really a fair comparison. The MMAE benefits might have been hidden because most people were getting surgery anyway.
Like trying to test a new fertilizer when everyone's using different watering schedules.
Exactly. Hard to see what's really working.
Right.
We need studies that compare MMAE to just conservative management or maybe different surgical approaches.
And like we talked about, that timing thing is important.
Yeah.
Earlier MNE, before the hematoma is huge. Maybe that's the key.
Could be. And one more thing. That MAGIC MT trial, it was in China.
Yeah.
So we got to be careful about applying those results everywhere.
Good point. Context matters.
It does. Why might the results be different in other places?
Well, different demographics, different healthcare systems, maybe even genetic differences that affect how how people respond to treatment?
All of that. So we need to repeat the study in different populations.
Absolutely. Make sure it applies to everyone.
Right. And also, gotta watch out for publication bias.
What's that?
Studies with positive results, they're more likely to get published. So it can look like a treatment's better than it actually is.
So just because we didn't see a benefit in one study doesn't mean it's not there.
Exactly. Absence of evidence is not evidence of absence, right?
Can't jump to conclusions based on one study.
Yeah. We need to look at all the evidence.
That makes sense. Okay, so let's get practical for a second.
Hey.
Say we have a patient who's a good candidate for MMAE.
Mm-hmm.
What happens next? What are the steps?
First, we got to do a thorough evaluation. Medical history, physical exam, imaging to see the size and location of the hematoma. Talk about their overall health, any other conditions they have.
So getting the whole picture before making any decisions.
Exactly.
How does the procedure actually work? Walk me through it.
So it's like a lot of other endovascular procedures. They put a catheter into an artery, usually in the groin or the wrist, and they carefully thread it up to the middle meningeal artery, which supplies blood to the membrane around the hematoma.
So going straight to the source.
Exactly. Once the catheter is in place, they inject this embolic material to block the blood flow. Ideally, this stops the hematoma from growing and helps it get reabsorbed.
Like plugging a leak in a pipe, preventing further damage.
Perfect analogy again. And the embolic material they use, it can be different depending on the case, the doctor's preference.
Makes sense. What about after the procedure? What should we be watching out for?
So usually they stay in the hospital overnight for observation. We need to watch them carefully for any neurological changes, bleeding, any other complications.
Like with any procedure, vigilance is key.
Absolutely. And we usually do follow-up imaging to see if the hematoma is shrinking.
Okay.
They might need rehab too, depending on how they're recovering.
Got it. Seems like there's a lot to think about with these cases.
There is.
But overall, it sounds like MMAE is a good addition to our treatment options for chronic subdural hematoma.
I think so. It's safe. It's effective.
Yeah.
And as we get more research on who it works best for and when to do it, I think we'll be seeing it used a lot more.
Agreed. And just to reiterate that shared decision-making piece we talked about.
Yeah.
Every patient is different. What works for one person might not work for another.
Absolutely. We need to be open and honest with our patients, make sure they understand all the options so they can make the best choice for themselves.
Couldn't have said it better myself. Let's talk money. You know, healthcare is expensive. Where does MMAE fit in, cost-wise?
It's a good question. MMAE, it might seem pricey at first.
Yeah.
But we got to think long-term too, potential cost savings down the road.
You're thinking fewer repeat surgeries, shorter hospital stays, that kind of thing.
Exactly. If MMAE can actually reduce recurrences and complications,
Right.
it could save the healthcare system a lot of money.
Which means better outcomes for patients, ultimately.
Absolutely. And it's not just about dollars and cents.
What else?
Resources, how we use them. Healthcare's in high demand, right? We got to make sure we're using what we have wisely.
Yeah.
And something like MMAE that could potentially shorten hospital stays, avoid those repeat procedures, that frees up resources for other patients.
Like a domino effect.
Exactly. More efficient system overall.
Makes sense. And it's not just beds and operating rooms.
Yeah.
It's about our time, too, the doctors and nurses.
Exactly. If we can streamline things for chronic subdural hematoma patients,
Right.
specialists have more time for the really tough cases, or to spend with patients, explaining things, offering support.
Optimizing the whole system. I like it.
Yeah.
So looking ahead, where do you see research and innovation going with MMAE?
Ooh, lots of exciting possibilities. Medicine's always changing.
It is. What are you most excited about?
For me, it's got to be developing even better embolic materials.
Like materials that are specifically designed for that middle meningeal artery and the membrane around the hematoma.
That's it. Maybe they're more biocompatible, release the medication more slowly, or even have drugs in them to help with healing.
So not just blocking the blood,
Okay.
but actually delivering treatment right there.
Exactly. And imaging technology, too, that's going to get better and better. And maybe even new devices, new techniques that make the procedure even less invasive.
Maybe even do it as an outpatient.
That's the goal. And then there's AI, artificial intelligence.
Oh yeah, machine learning. Everyone's talking about it.
It's a game changer. It could help us predict who will benefit most from MMAE.
Right.
Identify the high-risk patients, even tailor treatment plans.
Using data to make better decisions.
That's the idea, technology working for us. But even with all this cool stuff on the horizon, we can't forget about research, the basic science.
You mentioned that earlier. Why is it so important to keep studying MMAE?
Because it's still relatively new, this whole MMAE thing. We've learned a lot, but there's still so much we don't know.
Like those long-term benefits, really nailing down who it works best for and when to do it.
Exactly. And as we study it more, we might find new problems, new side effects that we need to address.
Always learning, always improving.
That's medicine, right? And that's why it's so important for clinicians to stay up to date.
Keep learning.
Yeah, be open to new ideas and help shape the future of the field.
That's a great message for our listeners. Never stop learning. Never stop pushing the boundaries.
It's a journey, not a destination.
Well said. Well, I think we've covered a lot of ground today. Explored this whole world of middle meningeal artery embolization for chronic subdural hematoma.
We have.
Talked about the evidence, the clinical side, the costs, the ethical stuff, all of it.
And don't forget about shared decision-making.
Oh, right. Super important.
And what's coming next, all the exciting research and innovation. And for clinicians, staying informed, staying involved.
Right. Got to stay on top of things.
What?
For our listeners, if you want to dive deeper into MMAE, we've got references and resources down in the description.
Check it out.
Read up on the research, see what's going on. Think about how this procedure might fit into your practice.
It's been great talking about this with you.
Me too. It's fascinating stuff.
Stay curious, everyone. Keep exploring.
Couldn't agree more. The world of medicine keeps changing, and we got to keep up. Disclaimer and bibliography in the description.